This is Dr. Ferdinand Chan. This is a technical pearl to gauge guide pin depth during transtibial pull-out repair of posterior meniscal root tears. We have no disclosures. Current devices do not allow for gauging the distance of the guide pin through the extra-articular bullet during transtibial tunnel creation without the use of intraoperative fluoroscopy. If pin deflection occurs, the guide pin may not penetrate at the expected location of the tip aimer. The meniscus root repair guide is assembled on the back table so that the bullet is set to 25 mm. The cannulated sleeve and guide pin are then placed through the bullet, and a label sticker is placed where the sleeve meets the bullet entrance. The components are then disassembled to prepare for intraoperative use. Attention is then returned to the operative leg. A small incision is made over the proximal tibia, and the bullet is then advanced so it is resting firmly on the anteromedial tibial cortex. If there are fewer than 5 marks visible, then one can assume that the distance between the tibial cortex and the root footprint is less than 25 mm. Here, 15 mm is visible on the bullet, so the pin should only have traveled 15 mm prior to reaching the footprint, and the sticker should be 10 mm from the bullet to indicate the guide pin has reached the tip aimer. Another way to remember this is, if you see less bullet, drill less. If the guide pin is not seen, assume the guide pin has deflected and it should not be advanced further. If there are more than 25 mm visible, one can assume that the distance between the tibial cortex and the root footprint is greater than 25 mm. In this case, the sticker should reach the bullet surface prior to penetration of the root footprint. Here, 45 mm is visible on the bullet, so the pin will have traveled only 25 mm when the sticker is at the bullet. The guide pin needs to be advanced an additional 20 mm. To remember this, if you see more bullet, drill more. The sticker can be moved distally 20 mm. Alternatively, the guide pin and bullet can be disassembled and removed from the field because the 2.6 mm cannulated sleeve is well fixated in the patient's bone. At this stage, the sticker is removed from the pin assembly, and the pin assembly is advanced 20 mm until the pin reaches the meniscal root footprint. Even with pie crusting of the MCL, the pin may be difficult to see if the guide is not removed from the joint. Once the guide pin is confirmed to be in the correct location, a loop wire is passed through the cannulated sleeve into the joint. The two previously placed leg-attached sutures through the meniscal root are grasped and passed through the loop wire. The loop wire is then reseated. The sutures are tensioned and secured over a button or anchor with a knee and 20 degrees of flexion. Thank you.